Hi, this is Long. Welcome to our video series on search patterns for the most common studies in radiology. Please note that this is an introduction to study interpretation. An enormous amount of detail is omitted for brevity. Continue dedicated reading, seeing as many cases as possible, and keep getting feedback from subspecialists during the course of your training. All right, so today we're going to talk about a basic approach to the pelvic and hip radiograph. As usual, you're going to get an understanding of what's going on with the patient, the indication, the history that leads up to the current study being done. Going through the views, you're going to look for any limitations that degrade your ability to look for subtle abnormality. And then, step by step, we're going to look at each of the osseous structures for subtle fractures, for osseous lesions. We're going to look for alignment and kind of placement of the femoral head and the acetabulum, and also making sure that the remaining of the osseous structures that we've seen in the osseous pelvis and the lower lumbar spine have normal morphology and position. We're going to look for deformities of the acetabulum, of the femoral head, the head-neck junction. We're going to look for degenerative changes. And then finally, we're going to look at the incidentally imaged soft tissue surrounding the lower extremities of the pelvis and otherwise that we see on the study. Okay. So here's a radiograph of the hip and pelvis where we're provided a single frontal view of the whole pelvis and then a frog leg lateral of the right hip, in some cases you might get a cross table lateral. You may have additional views of the pelvis inlet outlet views, but here we're just going to do a basic approach to this two view radiograph. All right. And so once we get a sense of the overall patient picture and take a look at the priors, you want to get a sense as to whether you can see whether there's any sort of limitations, particularly for the lateral view. If it's foreshortened, it can be very easy to miss subtle fractures. If there's a lot of overlaying soft tissue, if the exam is degraded, it is extremely, extremely easy to miss subtle fractures of the femoral head-neck junction, of the acetabulum, of the osseous pelvis on radiograph. So if the study is limited, and especially if the patient can't ambulate, or you have really any sort of suspicion for subtle or occult fracture, have a very low threshold to pursue repositioned repeat examination or CT MRI. Okay, and so starting with the frontal view, and a good approach is to take a look at every single cortex you can see, and also look, at also the medullary spaces in the soft tissue surrounding for subtle, very small osseous fragments. And this includes, if we're going to start with the hip, facing the femoral head, the head-neck junction, the intertrochanteric area, the area subtrochanteric. Look for subtle sclerotic foci, atypical fractures, especially below the trochanters. Okay, we're not just looking at the femur. You're going to take a look at the iliopectineal line, the ilioischial line. We're going to trace the entire osseous pelvis and look for subtle cortical irregularity, displacement of the pubic symphysis of the pubic rami. You're going to look to trace the sacral foramen. You're going to look, along the sacroiliac joints and at the lower lumbar spine. And then you're going to do the same thing on the lateral view, being particularly careful at the acetabulum, the femoral head-neck junction, and then you're going to get another view of the remaining osseous structure, so just to be particularly careful there. When we're looking at the alignment of the osseous structures, we're going to make sure that the femoral head is well placed as best you can on the provided views in the acetabulum. We're also going to look for any sort of subtle widening of the pubic symphysis, of the SI joints. Okay, and then we're going to ultimately look, and then you want to look at the contralateral side as best as you can, also on the single view of the frontal, for any sort of abnormal alignment. And then finally, what we're going to do is on both hips, do your best, within the limitations of a single view, we're going to look for any sort of, over coverage of the femoral head. You're going to look for, kind of that like pistol grip deformity, the head neck junction. You're going to look, in younger patients, you're going to look, especially if they have unfused physes, you're going to look for kind of that, deformity slippage that you might see with SCFE. We're going to look for deformity of the femoral head, as you can see, as sequela of avascular necrosis, inappropriate, very young patients and pediatric patients, which is its own topic, and kind of beyond the scope of a full discussion. You're going to be looking at the Shenton's arc. You're going to be looking at the Hilgenreiner's line, Perkins line, and acetabular angle to make sure there's no, to look for hip dysplasia, sequela of hip dysplasia. We're going to look for degenerative changes, which we see both as the hip and lower lumbar spine. You'll see that also at the SI joints, the pubic symphysis. And also in the appropriate circumstance, you're kind of looking for abnormal fusion, ankylosis of the SI joints. These are not going to be commonly seen, but something to just keep in mind every time you look. Once you've taken a look at all the osteostructures, their alignment on both the views, and being, very, very careful for solid abnormality, along the femoral head neck junction, intratrochanteric and subtrochanteric areas. We're going to look at the soft tissues, particularly, fat planes preserved around the femoral head and neck. You're going to look and just make sure you take a quick look at the bowel pattern, bowel gas pattern, at the, the pelvis soft tissues, and then the subcutaneous soft tissues, surrounding the lower abdomen, pelvis, the upper aspects of the lower extremities, abnormal calcification, lucency, kind of subcutaneous air, things like that. It can be very useful if there's any sort of question to go back to prior studies and get a sense as to the patient anatomy if you do have prior cross-sectional. All right, so let's go and do a quick recap of what we talked about. So the pelvic and hip radiograph, you're going to take a look at, as usual, what's going on with the patient, understand the limitations of the views you're provided. We're going to look at every single osseous structure on every view, being very careful to look for solid abnormality, and having a low threshold to do additional imaging. We're going to look for, preservation of the femoral acetabular articulation and the other sort of articulations in the osseous pelvis and image lower lumbar spine, looking for deformities at the femoral acetabular articulation, looking for abnormalities of the SI joints, and then eventually looking at the soft tissues, both subcutaneously and incidentally image of the lower abdomen and the pelvis.